Good evening, everyone, and welcome to our ADHD in Children and Teens, an update on assessment, treatment and shared care webinar. My name's Bianca Forrester and I'm Clinical Lead of Innovation and Learning at the Western Victorian PHN, and I'll be your facilitator this evening. I'd like to begin by acknowledging the traditional owners and the custodians of the lands, unceded lands and waterways, the Wadawurrung, Gulagajin, Gadabanud, Kirrawarring, Peakwarring, Gudinjamara, Jabwarung, excuse me, well, I'll give it a go. What Jabaluk, Jajawarang, Jadawa, Jali, Wegaya, Jupagalg and Jadwa peoples. I'm sorry, I don't normally read all of that, but I really wanted to do that tonight. We recognise their diversity, resilience and ongoing place at First Nations people hold in our communities and pay respects to elders past and present and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisations and really will work towards this process of treaty and truth-telling. So just a little bit of housekeeping. So the majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel, and we will put a link to access our recorded webinar events in the chat. I have our upcoming events on the screen. You can register our events for our events on the website, and we'll put a link in the chat for this also. So please make note of the Western Victorian health pathways relating to this topic that are on screen at the moment. And you can see there's a wealth of resources there. And another piece that we wanted to flag tonight is the Western Victorian PHN want to understand the needs of our communities that we serve. So at the moment, we're really doing a lot of work in preparation for our 2024 needs assessment, and a consultation process is underway. Please follow the link and tell us what health issues are important to you and to your community. So do promote this with your community, but as a community member in our beautiful region, we want to hear about what faces you and even your families, so we can develop some really rich insights that will help us think about some of the gaps and some of the opportunities that might come ahead. So if you've entered this webinar not displaying your accurate first and last name, now I think we probably can't see. Jade, are we seeing everyone's name? I guess when you do, if you do put a question in, we'll see your first and last name. So just have a look and put your full name in the chat box. Only admin will be able to see this, and this will ensure that we can issue a certificate of attendance. I see, that's right. So just so we can issue your certificate of attendance for either RACGP ACRM or for practice nurses for professional development. So for this evening's webinar, all participants will remain on mute. And if you have questions, please pop them in the Q&A box. I will ask them tonight. I'll be moderating the Q&A, and we encourage as many questions as possible from the audience. And I think we'll have a really rich and lengthy discussion between our wonderful presenters and panelists and yourselves this evening. Now, in terms of the survey, we will evaluate as we do with all events, and there is a link in the chat box to complete the survey after the webinar, and it will pop up automatically on your screen when the webinar finishes. We really do value your responses. It really helps us improve what we do. So I would now like to introduce and hand over to our speakers. So for this evening's webinar, we're delighted to be joined by a panel of paediatricians by Associate Professor David Fuller, Dr. Lawrence Gray, Daniel Peyton, Pippa Shilson and Dr. Mia West. I'd like to now hand over to Dan Peyton.
Thanks so much for joining us, everyone. I really appreciate your attendance, and I think this is such an important topic for paediatricians. It's a huge bulk of what we do in the community, and really a hot topic as well around ADHD and mental health, especially in COVID, but not just related to COVID. Mental health is a rising tide of mental health problems in Australian children that's been increasing over the past 30 years, and COVID is just another speed bump in that increasing ramp of problems. So it's good to talk about ADHD, and most children with ADHD don't get professional help. So I think it's really important to flag what ADHD is and how we manage it, and importantly, sort of how we manage it in our local community. So we might just shift to the first slide with a questionnaire. And I feel like Bianca's already mentioned there's a few questionnaires, but this one I think will be particularly useful in helping understand, one, how we can help GPs before they're referred, or when they've been referred to a clinic but haven't been seen. As we know, there's a long wait list to be seen. I don't know if anyone can hear my 2-year-old in the background, but it does sound like she's got emerging ADHD. So I apologize for that, but it's not her fault. It's a mixture of environment and genetics. And secondly, the other part of the questionnaire is around how we can support GPs whilst they're being seen in the clinic with information or resources or whatever else. So if you get a chance, I'll wait 60 seconds now to fill out those 2 questions. Apologies for the wordy questions.
So I did this the other day. Just grab your phones and pop your camera up to the screen. You'll see the QR code will pop in if you haven't done this before, and jump in. And that survey is pretty easy to access, actually. You'll have my responses in there, Dan. I'm sorry if I skew your data.
I wondered who that was. I was already had my test. So yeah, hopefully we can get a few people. As I said, I'll just wait that 60 seconds while everyone has a crack at it. Alrighty, so we might move on to the next slide. We'll wait for that to filter through for Typeform. If you're halfway through filling it out, please persist in getting that filled out, and I'll hand over to Philippa.
Hi everybody, and thank you so much for coming this evening. Before I launch into the case study, which is actually a female teenager who I've known for about 6 years, I wanted to be clear this evening that the young lady I want to present is actually far from typical of the patients who often come to paediatricians or referred into the branches clinic for ADHD care. The typical kid that we see with ADHD symptoms is a primary school age male, young boy who may have made a good start through kinder and prep, maybe had a bit of extra supported literacy work in prep or grade 1, has found that as school gets harder and the expectations for their social behaviour at school become much more streamlined, all the other kids in his class are likely to be picking up on the cues and getting the hang of their daily routines and how they need to conduct themselves in the classroom and in the playgrounds to be a thriving primary school age Aussie kid. The kid with ADHD, however, really struggles to pick up on these cues because they're so distracted and impulsive. They don't really understand why the other kids around them are learning to read and write and learning their basic arithmetic so quickly. And they tend not to understand why they're always getting in trouble. They sometimes feel like they're being picked on by the teachers or that their parents are constantly nagging them at home. So these boys often will do beautifully with a tiny dose, relatively low dose of stimulant medication. Sometimes they'll do well with good supportive care in the classroom and understanding parents and making sure that sleep, nutrition, daily care routines and clear expectations and small group learning, sometimes that'll be all that's required and stimulant medication might not be needed. So that's a pretty typical situation of most of the patients that we would see. And thereafter, as is common with a lot of chronic and medical conditions in paediatrics, all of the rest of the work that we tend to do is around making sure that we've got a Goldilocks zone of medication care, that we're achieving good suppression of ADHD symptoms while hopefully avoiding the worst of the side effects, and then making sure that the kid's life in other respects doesn't go off the rails. So that's a pretty typical young boy ADHD kid, but the case study I want to present is a little bit different. So this young girl came to me at the age of 10 and really had a very supportive, stable home life in outer suburbs of Geelong, no chronic medical illnesses. She'd had clear-cut mild learning difficulties evolving through primary school, and by grade 2, 3, 4 was starting to fall behind the rest of the class groups. That in terms of the quality, the output of her classroom work, and she just started to feel like she was being left behind. Interestingly, she would always read for pleasure and for relaxation at home, which I thought was a real strength. So her parents had already done quite a lot of work behind the scenes. They'd already taken her for an audiology assessment because, it's a pretty common complaint for parents of kids with ADHD is the kid has selective hearing and they'll only listen in to buzzwords that they're already primed to pick up on, like ice cream or iPad. The audiology was normal, but the young girl progressed with auditory processing assessment that was quite abnormal. The auditory processing technician suggested, look, if you've got slow and erratic auditory processing, how about you try a CogMed course? And her parents invested a lot of time and effort in CogMed with this girl. The CogMed trainer then offered a private IQ assessment, which in my opinion really wasn't necessary. I thought it was very unlikely when I met this girl that she would have a significant intellectual disability. The neurocognitive assessment found full-scale IQ in the normal range across all domains, but that assessment also diagnosed inattentive type ADHD. So the parents came to me with audiology, auditory processing, neurocognitive assessment, and a diagnosis of inattentive type ADHD. And so it was my job to do the medical workup. I see this as being a fairly straightforward sort of template really approach to double checking that I'm not missing a genetic, medical, social or mental health cause that would be giving symptoms consistent with ADHD without there being true executive function impairments. This girl clearly, we know she doesn't have an intellectual disability, but she also had no Asperger's or neurodivergent red flags. She had no core behaviour disturbance and was not getting in trouble at school or at home. A clear concern really, she had recent optometry and had never had a seizure. Her sleep was basically normal, but she'd always had mild initial insomnia, and that had been a long-term problem for the family. She had normal thyroid, normal clinical exam, early signs of puberty evolving at the age of 10, mild generalised anxiety that was apparent throughout the conversation with her parents and also with the young patient. We did an ADHD screening tool with school and with both of her parents. Her mum was in the middle of chemotherapy for breast cancer, but mum and dad separately completed the parent Vanderbilts, and then so we had different degrees of feedback about how this young girl was going. And apparent from the Vanderbilt scores, coming from school in particular, was that yes, the school teacher agreed with inattentive diagnosis, but she only had a very mild impact on her classroom progress, and the teacher really was not flagging that she was falling dangerously behind. So we linked her in with counselling support about the insomnia and the anxiety, but obviously also related to her mum's diagnosis and how the whole family was coping with that. Gave her some written tips, both for parents and also for her classroom teacher. And we had a long discussion around different avenues of non-pharmacological therapy. So this young girl, basically at the age of 10.5, nearly 11, headed off into grade 5 and went back to the GP with no medication started, but with a clear-cut plan for addressing anxiety, mild initial insomnia, and classroom inattentive, distracted ADD. I'll hand back to Dan here.
Thank you for that, Philippa. Okay, so now we're just going to talk a little bit more around an overview of ADHD to provide some background and hopefully some pragmatic advice on how to identify it, and understanding a little bit more about how we manage it as well. Because it's interesting, I'll put a link in the chat in a moment with the results of that survey, but the information that GPs are telling me that they want when they've referred a child to the clinic, but they're waiting the 12 or so months to be seen, is around how to help the child without medication. It's number one, 73% of respondents wanted to have more information about that. And next on the list was other child mental health services that can help, which is in that same theme of what are the strategies and what are the services that we can refer to or use to help families while they're waiting to be seen. Okay, so we might move to the next slide, please. So first of all, as with all mental health problems, we will begin with the DSM. It's an easy tomb to sort of pour through. I look at it regularly during my clinic day. I've got a few shortcuts on the computer to refer to it, but I think in the terms of ADHD, a couple of key points are, one is that you require 6 symptoms of either inattention or hyperactivity to be persistent for at least a 6-month period, and that this is causing a significant impairment in their life. How significant is significant? It's a tricky one to answer and one that I struggle with on a regular basis. And that's where a lot of the nuance in diagnosis can come. And it needs to be present in at least schools, 2 settings, such as at school, such as at home, or, as I'm saying personally, more important socially, in relationship with peers, because that's so important for a child's well-being and impacts so much of their life. Okay, so we'll move on to the next slide, please. And I think one of the most useful tools that we have in terms of understanding how the DSM criteria can apply in everyday life and screening for ADHD is around the Vanderbilt. And there's a few different tools out there. The Vanderbilt is the one that I trained on, and this is the one that I'm sort of most familiar with. It's freely downloadable on Google. Just have to search Vanderbilt ADHD parent or Vanderbilt ADHD teacher, and it will come up right at the top of your list. And this groups the first 18 questions on the Vanderbilt specifically in relation to the DSM criteria. So importantly, the first 9 questions are around inattention, and then the next 9 questions, 10 to 18, are around hyperactivity and impulse control issues. So if these are happening as a crude measure, if these are happening often or very often in 6 or more of these domains of inattention or 6 or more of these domains of hyperactivity, it's very suggestive of ADHD, and the evidence is reasonable for this. Although there is a lot of nuance in this, and the screening test can miss a number of cases, especially bright, inattentive kids. They can sometimes, the symptoms can be missed in teenagers. So it's important to know that as well. So if there's a qualitative report of the ADHD, but not as much quantitative from this measure, they can still have ADHD. But I think a very useful tool to be able to Google quickly whilst you're in the rooms and hand to families and looking for those 6 or more symptoms of inattention or 6 or more symptoms of hyperactivity, impulse control in the often or very often group. Next slide, pretty please. So then we can look at the epidemiology of ADHD. And we need to know that ADHD is fairly common. It affects around 1 in 10 Australian children, Australian boys, and slightly less girls. And what's interesting is this is from a fantastic representative survey, by the way. They approached 78,000 households across the country in 2015 and interviewed every one of them that had a child in the household, doing up to 6 diagnostic tests for 60 minutes. I wish I could provide that sort of service for the patients that I've seen. But a wonderful tool in understanding the prevalence of these mental health conditions. And interestingly, ADHD has actually gone down over time, only slightly. So it's not increasing. It has gone down slightly. You can see in 1998, 9.8% had it. In 2014, 7.8%, which is when they did this study. And there are relevant risk factors for having these ADHD problems, low SES, blended families, which is probably, potentially there's genetic factors in this, but also may be related to greater functional impairment in those settings. You might have the same level of symptoms, but when there's other factors in the environment which reduce the resourcefulness of the family, that can cause a greater impact, which I think makes sense. Okay, next slide, please. So I think it's important to have a little bit of discussion on how we manage ADHD, because once it's diagnosed, obviously management is really important. And the goal of management, as Philippa mentioned before, is around symptom control, usually with medications, the only way to manage symptoms, and then reducing the impact of those symptoms on their day-to-day function, i.e. strategies, therapies, sometimes alternative therapies, and the like. And the goal, the sweet spot, the goal for that medication is to get that symptom control with as fewer side effects as possible. So reducing the frequency of those symptoms from often or very often to sort of a more normal range around sort of sometimes or sometimes and often with as fewer side effects as possible, as I said. And there are a few medications that we have to do that. Okay, we might move to the next slide. And so just to provide you a little bit more around the detailed treatments that are available, there's not many for ADHD, so it's a fairly short slide. So we've got our pharmacology, we've got our short-acting medications, our dexamphetamine and our Ritalin, and our long-acting stimulants, Vyvanse, Concerta, and Ritalin LA. There are a couple of other agents, being Intuniv and Strattera, but every time I try and use them, I do so with great hesitation because I know how ineffective they are compared to the standard stimulants. The non-pharmacological therapy, I think we can break it down to a few things. Number one is strategies for the school, strategies for the home. And as part of that as well, thinking about things like parent training, which isn't widely available, but you can get group programs to help modify behavior, which is a very important one. Sometimes you can look at alternative therapies, things like fish oil, excluding some food additives, red yellows. So that works in a very small, to a small extent in a very small number of kids. So it's not something that I have any families continuing on for a long term because it just rarely causes any really much help from that. And the managing comorbidities, which is a big one. So this is one where you can get great functional improvement in the child without having to rely as much on the symptom control. So that's managing their anxiety, managing their behavior problems, identifying specific learning disorders and managing those is a very useful part. And that's something that's widely available, I think, to all GPs, is around managing anxiety, strategies, psychologists, online programs like Brave Online, and behavior problems, i.e. strategies, group parenting programs like Tuning Into Kids, my favorite of all the group parenting programs that are available. Everyone in my family has done it and I highly recommend it. I recommend it every day. Some things that really don't work or the evidence is not favorable for objective outcomes measured over time, things like neurofeedback, talked about cognitive training, digital interventions, or importantly, CBT without medication for ADHD symptoms, which is an interesting one because we talked about other therapies, other therapists that can help children with ADHD. They can't help the core ADHD symptoms, but if they've got persistent symptoms with impairments in behavior or anxiety and that sort of stuff, we can hopefully control their symptoms and give them CBT help if they're still having issues with those other aspects of their life, anxiety, behavior problems, social skills difficulties. All right, next slide. So this is a really handy sheet in terms of helping families identify the strategies that are most likely to be useful at home or at school to help with self-confidence, to help with social skills. It's readily available on Google, very quick Google. And I've already talked a little bit about fish oil and excluding some food additives. So we'll move forward, but this is a very handy strategy list to hand all families, even those who you don't think quite reach diagnostic criteria for ADHD, but they've got maybe 5 inattentive symptoms or 5 hyperactivity symptoms. They could still benefit from these strategies listed here. Okay, next slide, pretty please. And also thinking about the related comorbidities that are associated with ADHD. Again, great functional impairment can be caused by these associated problems. And until we identify them and manage them accordingly, they can still have this ongoing functional impairment. So helping them with the emotional dysregulation and behavior problems, helping them with the anxiety or mood problems. And mood problems are very common in children with ADHD, helping them with their tics or learning disability. All righty. So the next part is around medication. So when to start. And this is a sort of case-by-case kind of basis, but there's a few different schools of thought. We can trial strategies for a period of time. Environmental modifications is another word for those strategies to see if it reduces the impact of those symptoms. Or we can offer families a combination of the strategies and medication once they've been diagnosed. I haven't referenced the Australian guidelines on this, which came out, but they're a good read if you have a few hours. It's 160 pages long, but they're a good read for helping frame how we approach this combination of medication and non-medication treatment. I think really all families should be offered both, but it's a case-by-case basis for whether or not they want to pursue stimulants based on the risk or benefits perceived for their child. The references, the guidelines that I'm referencing here are the NICE guidelines from the UK. But really it's about if their symptoms are causing a persistent, significant impairment. There's that word significant. How significant is significant? That's sort of an interesting debate. After some environmental modifications have been implemented, then medication is the way to go, whilst continuing the strategies and environmental modifications. And not every family has to have it. It's not a life-saving medication, but it's one that should be offered and can make a big difference to children's and families' lives. All right, next slide. So just to finish on in terms of a quick overview of the ADHD and treatment, hopefully I haven't gone over time and wasted too much time, and I haven't really spoken much about side effects, so I might try and squeeze it into this slide. But I think a couple of important parts about stimulant treatment, and this is not about Intuniv or Strategia, it's a little bit different to that. This is about our Ritalins, Concertas, Vyvanse, dexamphetamine. We can stop them at any time. So if a family is experiencing problems related to the medication, I often give them advice to stop them. And as GPs, I think that's a good plan to do, is to, if families losing trust or losing faith in this process or this medication, it's okay to have a pause and reassess. And also we know that when we start ADHD medication, this is around the country, when we start out ADHD medication, 40% of the time they're not continuing that medication 6 months down the track. And there's probably a bunch of reasons for that. It probably hasn't worked as well as what they wanted, or it's not addressing the things they really wanted it to address, or they're having a side effect and didn't realize that there's 5 other medications that may be more suitable for them. So I think continuing the trust in that process, and if a family is losing confidence, it's something it's okay to have a pause and reassess. A lot of the things that we do in clinic is about optimizing that dose of that medication. We might set a high dose that we sort of are comfortable with prescribing, and then there's some trial and error to find the right dose that suits that family based on the effect and the side effects. And for families that have had difficulty in that process in finding that right medication, sometimes we go quite slow and have pauses in between those changes. But a couple of key points is, if we're having reduced appetite associated with the medication, this is a very common side effect. It affects around 8 in 10 children who are on this medication that have a reduced appetite. We can increase the calories before the medication or after medication's worn off, or give them breaks on the weekend or on school holidays. About half of the families continue it on weekends and school holidays. Half don't. It just depends where they're impaired from their ADHD and what the family wants to do and the benefit from the medication. Or we can reduce the dose and hopefully not lose that benefit. With the anxiety, that's a really tricky one. Often need to reduce the dose or stop it, because anxiety can sort of hang around, unfortunately. Once the neurons that fire together or wire together, it gets harder to break that in time than we can do. Problems with sleep, often we want to stop the midday dose if they're on a short acting, or reduce the dose. If they're having tics, we can reduce the dose or stop entirely. Cardiovascular problems, this is a rare side effect, but one that's important to recognise. So if they are having concerns around that, often we do need to stop it and review them and consider when we need to get a cardiologist involved. And then there's also this emotional ability that can happen with the medication as well. That can happen when they're on the medication, so when the medication's there, which usually is a side effect, and we need to reduce that dose, hopefully still getting the benefit from the medication without the emotional ability side effect. Or if the emotional ability is where the medication's sort of wearing off, we can actually go up or switch to a long acting, and sometimes that can help it, which is what I've done with a family today. Rarely, so anxiety is, we have an increase in anxiety with stimulant medications about 1 in 4 times, but rarely, about 2% of kids can have a depressive type effect from these medications. So it can lower their mood, and then with lowered mood, that can make all their ADHD symptoms worse. And then when their ADHD symptoms worse, they can make their mood lower. So there's a whole cycle that gets, so when that's happening, if we think that it's lowering their mood, usually I'm fairly quick to having a pause in that medication and reassessing. Alrighty, so now we might move on to the next case study. Thank you, Philippa.
Thanks, Dan. So we'll pick up where this young lady came back to see me about 4.5, 5 years later. She's now in year 10 at the local high school. She'd had an unusually okay pandemic. She had, her whole family had buddied up with their neighbours and formed a bit of a bubble at the beginning, really, of the lockdowns. Her mum had successfully, worked her way through the chemotherapy and had been cancer-free for 2 or 3 years by the time I saw her again. And she'd managed to cope pretty well with online schooling. She'd also become an elite athlete. She had taken up team ball sport locally and had worked her way rapidly through the ranks. And she now came back, working her way through year 10, doing one VCE subject. And she gave a very clear and articulate description of the impact that her inattentive ADD was now having on her school progress. The generalised anxiety disorder that had been lurking in the background when I first met her at the age of 10 had really strengthened after the pandemic had effectively sort of finished and she'd gone back to everyday schooling. The anxiety had strengthened and the insomnia had worsened significantly. Also, with puberty progressing, a lot of the teenagers will naturally feel like 11 o'clock midnight is an okay time to switch the lights off and hopefully put the phone on charge. But coming into clinic, she was describing she was not enjoying school. She was constantly worried. She felt in almost all of her classes she was zoning out and wouldn't be able to reorient her focus to block out distractions and start taking in the learning that was happening around her. She had also started having panic attacks. Unfortunately, one of her sports coaches sounded like he'd never watched an episode of Ted Lasso in his life. She'd had a couple of occasions of being sworn at by this guy, and one occasion when she'd been sitting next to him on the bench and he'd lost the plot at one of the other players on the field and had snapped the clipboard in half and thrown the clipboard near where she was sitting. So she was sort of describing articulately, the panic and anxiety that she was feeling. She was still comfortably passing the year 10 maths that she hated. She was still going to every class and attending 5 full days of school a week. She also had, was geared towards doing psychology further down the track and was doing VCE year 11 psychology in year 10, but hating it and really surprised that she was hating it and struggling to learn. So we took a lot more history and I started seeing her individually as well as with her parents, working through the head screen for adolescent health risk factors. Her home, social life, sexual health and menstrual health were all fine. And importantly, I'd spent quite a bit of time delving in, looking for the disordered eating or body dysmorphia that can often go with elite athletes, both men and women around that age. She wasn't vaping or getting addicted to any other kind of substances. She wasn't addicted to social media or any other kind of screen use. And really, she had a very healthy daily self-care routine. She was excelling in school at subjects that needed hands-on skills. So anything creative, anything where the teacher's main mode of both teaching and assessment involved small group projects. Also, obviously, she was absolutely acing outdoor ed and PE. She was starting to hate state-level sports competition, crashed out at Nationals Recruitment Day and described quite articulately that she felt great relief when she found out she hadn't made it through the national team. Clinical examination, again, normal head to toe, and we did full blood count, thyroid function, including T3 and T4, a ferritin, which I find is the only really useful marker for circulating available iron to red blood cells, and a 12-lead ECG, which were all normal. I was pretty worried about her description of having multiple points throughout the day when she was zoning out and finding it hard, feeling almost disembodied from the other students and teaching happening around her and struggling to re-engage with class. I was also aware that she was probably coming up to doing her learner permit to get started driving. So it was a bit of a crude test for absence seizures or complex partial seizures. She and her parents agreed to doing a 4-minute hyperventilation test in clinic rooms, which is something I only do occasionally and certainly only when there's another medical doctor in the same clinic with me. I go and let them know that that's what I'm about to do. Once in 14 years, I've had a kid who did about 30 seconds worth of the hyperventilation, went into an absence seizure, and then had a short generalised tonic-clonic seizure in clinic, which self-terminated within about 3 minutes, but certainly gave everybody a hell of a fright. Anyway, so I always do informed consent before we do that. but that would certainly, in my mind, in combination with complete normal clinical examination, the hyperventilation test being normal, not eliciting a seizure, in my mind meant that we didn't need to proceed with a full EEG, which may have been 6 to 12 week wait. So we lined up this young lady with some Mood Gym online CBT work that she would be able to work through while she was on the bus on the way to school on her phone, for CBT, focusing on her anxiety and insomnia, and teaching her a couple of strategies for the panic attack. There's also an app which is mainly directed at teenagers and young people who self-harm without suicidal intent, as a way of expressing emotional distress, with often fairly common, unfortunately, underlying mental health issues driving the self-harming behaviours. The Calm Harm app is certainly not for youngsters, but for teenagers and young people, has a lot of strategies on that app for mindfulness training, counting down your breathing, finding different ways of venting emotional distress in a way that's socially appropriate, whether you're on a bus or in class or at home in your bedroom, without actually resorting to self-harming and without having a full-blown panic attack. So with all of that already in place, we started low-dose fluoxetine in August last year. And when I saw her in October, there had been a remarkable response on only 10 milligrams disposable tablet of fluoxetine. She was sleeping much better. She'd quit the state level sports team and taken up part-time cafe work. She had a boyfriend. Her marks on the fluoxetine low dose were about the same as they had been the semester before, but she was less stressed about it. She also gave an insightful and articulate description of the fluoxetine not treating her ADD symptoms. So we did a stimulant side effect rating scale on the fluoxetine alone. This is a checklist that I use very consistently before I would commence a patient on stimulant treatment for ADHD. It's a checklist that basically asks patients, and it's a conversation prompt really, asks patients to rate how many times in the last fortnight they've experienced, and then there's about a 15-point different symptoms that are really common side effects of stimulant medication. So we did the side effect rating scale on just the fluoxetine to use as a comparison if we were going to start stimulant treatment. I talked with the young girl and her parents again, and they said, yes, we think we might try a small dose of Ritalin LA, which was phenomenally successful. And fairly shortly after starting Ritalin LA, she asked to wind down and stop the fluoxetine and wanted to continue on just the Ritalin LA 10 milligram. That's where she's at now, finishing up year 10 and heading into VCE. The other conversations that we've needed to have about the stimulant treatment, I will always talk through the side effects in quite a bit of detail, because that's where a lot of families will come unstuck. I try to get an agreement with the parents and with the young person that if there are shifts in their weight due to the appetite suppressant effects of the stimulants, then often we can work around that the way Daniel's described, trying to have a double breakfast before the stimulant tablet is taken. And then the parents need to expect that between 4 p.m. and 10 p.m. that night, their teenager is going to need a main adult-sized meal about every hour and a half for that 6 hours to try to ameliorate the appetite suppressant effect of the stimulant tablet working through high school learning classes. The other aspect of it, I say, okay, well, that's the appetite suppressant. We also need to address insomnia, and now is the time to tune up your bedtime habits and get the screens out of the bedroom if you can. We worked through that in some detail. The one symptom and side effect of the stimulant tablet that I take responsibility for on my own is the kids' personality, that in that small group, only a couple of % of kids who would start either dexamphetamine or Ritalin only a couple of % of those teenagers, when they start the stimulant, it's as if their personality goes on mute. It's as if the bounce has gone from their bungee. They may be learning beautifully in class. Their grades will have jumped. The teachers love it. The parents love it. But the kid, their sense of humour, their sense of play, their joy in the world, and the rascal nature that makes them who they are, is the volume's turned right down. And it's as if you've lost the essence of the teenager that was there. I take responsibility for that and say that if I see that happening in clinic, if it's clear that that's been the effect of the stimulant tablet that I've prescribed, I'm not writing any further scripts. We need to cancel that medication, put it down on their meds list as if it's an allergy, and consider all of the other pharmacological strategies, fair enough, but that one medication, we can't use that one again. So at that point, where do we go from here? She's on Ritalin 10 milligrams long acting. Does she come back and see me every 6 months until she's 18? Do we try to work out whether through VCE, can she get enough strategies and post-it notes, reminder systems, other ways of trying to get a better fit between her executive function skills that she's already got and the workload that she has in front of her to try to tackle each day? Do we try to get her off her medications once she's finished VCE and turned 18? Or do we try to transition her to adult ADHD care? And this is the point where I don't really have any more answers, so I'll hand it over.
Great. Thanks so much, Philippa and Dan. And I am loving having Dave Fuller in the comments, providing the wisdom that he's not saying out loud in the presentation tonight. So I'm Lawrence Gray. I'm one of the paediatricians as well, and I'm here to talk mostly about the clinic that we set up just over a year ago called Branches, which I hope by now all of you are familiar with, but we're going to go through it in a little bit of detail. And then we're going to think about it, I guess, how it relates particularly to ADHD and how we can share the care of these patients. I've already seen some great questions related to that in the Q&A that I think are really already firing my brain for what we need to continue to improve about this clinic. So the first question seems obvious, why change the model of pediatric ADHD care? So even though the overall numbers of children being diagnosed with ADHD may be the same on in terms of the data that we've collected, we still all feel, I think, that there is extremely high and increasing need and demand for pediatric care of these patients, either with a paediatrician or with a GP. And I know that that's also extending to an increase in demand for adult ADHD care. All of us working in isolation, it has essentially stopped working. It's inefficient and it's failing to meet the demand. And by working in isolation, I mean being siloed as a paediatrician and siloed as a GP, regardless of whether you work in a big practice or not. Essentially working on your own in a room is just not enough at the moment to meet the huge numbers of patients who need our help. And there's lots of evidence showing that if we can assemble multidisciplinary teams and shared care, that it's actually better for everybody. The patients enjoy the opinions and expertise of a number of people simultaneously. The medical team get the support and the education and the extension and the push that comes from sitting with colleagues whose opinions you value and learning from each other and trying to understand more about the way that other patients are cared for by those colleagues, makes you a better doctor. And I think also by working with more broader teams that include lots of allied health, we actually get a deeper insight into what it is that really troubles patients with ADHD in the community and the kind of deficits they suffer from. And they provide a really important link back to schools where we know that the highest demand is put on these kids, and therefore the place that they're most likely to struggle in a way which affects their long-term ability to continue in school, continue in university or further training, and guard against slipping off into a different path as they get older. And we wanted to include GPs in this multidisciplinary team. And interestingly, perhaps surprisingly, the federal government has helpfully imported models which that actually support doing care this way. So there is actually better funding support when we engage in team-based care. So that's why we came up with branches, and branches stands for the Barwon Regional Adolescent and Child Health Shared Care Clinic. This is the website, which is up there, and you can find it at the Barwon Health webpage or by Googling it. And obviously we're going to share these slides tonight. I'm not sure if that got stated at the start, but the plan is that we will be able to distribute these so that you've got all these resources and bits and pieces which everybody's prepared for you tonight. When you click on the branches link, you get taken to some downloadable information, which includes a bit of a description of the service model, which I think is helpful if you've never looked at it before, but perhaps will become less and less relevant as everybody gets more comfortable with what branches is, and some patient and family information, which we think is important for managing the parent and patient expectations around what this clinic is. So when we started it, we had really clear aims that we wanted, for the first time in recent history, a equitable, public, accessible paediatric clinic that's open to all referrals of children less than 18 years old, which was based around multidisciplinary care because it's better for everyone. What we really wanted to do was aim for what we've termed shared care with GPs. And I think in the context of ADHD, that's particularly important, because what we're really asking our GP colleagues to take on is co-prescribing. And if we can co-prescribe with support, it really allows movement of patients out of the clinic as much as it allows patients into the clinic, which will create churn and flow instead of long lists that get only longer because we are holding every patient for ongoing prescribing. It's a clinic that doesn't need repeat GP referral, yay. So every time the patient comes to see you, you're not there doing paperwork related to yet another referral. If they make an appointment with you, it's because they want you to address a challenge. Well, I hope that's why they're making the referral to you. And we wanted to integrate better with our local support services. So we wanted to expand the team so that we could have school-based liaison and conversations, so that we could talk to all the support services that sit around some of these families and children in a more direct way, and so that we could actually allocate time in shared care case conferencing to talk about challenges. And we tried to intake everybody with a learning behavioural or a developmental problem with an intake assessment before the clinic to help guide the appointment. And I just want to put it out there, a bit of a plug, that actually next year COLAC is coming. So there is a version of this which we are going to start from February next year, which will see the COLAC patients. And if you look at that map, imagine an arrow heading west. You know, I hope that in time this model is effective and satisfactory and meets more people's needs, and we can actually roll it out further. I think the reasons why we think it will be better are obvious. You know, we've got an ongoing public general paediatric service. But the other thing is that we're training local GPs. So Mia, who's just popped her face back on down there, and the rest of the team who are talking to you tonight have either been part of branches or are currently part of branches. And Mia's one of the GPs, along with Emma Divany and Corshi De Silva, who are part of our clinics. And I would say, you know, it's been a genuine, surprisingly fun time having us all in together. I don't think we all knew exactly how it would go at the start, but it's been great. And I think that we've learned a lot from each other. We wanted to reduce the workload. We wanted to use our pre-referral assessments to streamline and speed up our appointments so that people can move through more quickly. But ultimately, we wanted to get a better understanding of the patients. And when I hear Philippa give her beautiful, detailed, insightful commentary about that patient she's known for that amount of time, it makes me realize how important it is that we do our best to understand the full context of our patients. And I know that time constraints are the enemy of all of us, but when we are able to, clearly both the patient and ourselves get more from the clinic. Want to show you what it looks like quickly. So we've got a big team at every branches meeting every week. We have a multidisciplinary case discussion review of all the patients that are going to be seen that day with the paediatricians, the GP, our social worker, our allied health coordinator, our clinic coordinators, and our GP and paediatric trainees, hopefully. We've certainly had a bit of both at the start, but we've got some paediatric trainees, and we really want to have the support of our GP colleagues in helping train our GP trainees through this clinic as well. And I don't know what's happened down the bottom with the during other TMs, but we'll keep moving on. So Mia's going to give you a little bit of a reflection when it's her turn, but I just wanted to say that what we think the GP is doing in branches, they're employed for up to 2 years, which we wanted to do for a long time to build up quite a lot of experience and effectively have them as expert paediatric GPs at the end. They're obviously closely participating in the case conferences, but also then moving to fully independent consulting. And I think at the moment, we're 12 months in, and mostly I'm finding I'm getting in Mia's way rather than adding a lot more. And I think that's exactly the way it should be. And it's really actually heartening to feel superfluous in that discussion these days, because I think we're really able to do a lot of work in our case conferences now that set us up for successful consults. And we wanted to use our connections to you. We want to get to know the GP network better and actually roll out some more targeted teaching and in-depth teaching about ADHD care and management between us. But obviously there's problems, because there always are, because it's medicine. So, demand still outstrips the supply. We're getting 120 referrals per month. We can see 48 patients that are new per month. Do the maths, it's not great, but we will get better. And we wanted to get better while maintaining some of the quality of the clinic. So we want to be available for GPs. We want to have discussions without referral necessarily. And we want to be supportive of shared care and co-prescription. And we obviously need to improve the information flow back. And then for you, we'd love you to join. We'd love you to use our referral net template and participate in shared care in the way that we can all get something from it. But please be patient, because I am literally building the plane as we fly it. And I am genuinely and very, very intensely interested in your opinions and feedback, because we're trying to make it better as quickly as we can. But we're having to do it while seeing all the patients at the same time, because the demand is so high. So I will respond, I will listen, and I think that I have a great team here who all want to make it better as well. So I'm going to flick across to Mia to give us her insights into what it's like to co-prescribe in GP land and to sit in the clinic. Thank you.
Thanks, Lawrence. So before I start, my name is Mia. I'm a GP in North Geelong, and I've been working in the branches clinic for a year now. And I want to talk to you today about co-prescribing, which most of us know how to do, but for things that we're not familiar with, we can hesitate, or we can think, oh, we're too busy and I don't want to learn that. And, it can get into the too hard basket. But I want to say that when the patient comes to see the GP, as we know, it's not just a script. We're not just co-prescribing. We're reviewing that patient and considering all of our usual GP things, such as the social well-being of the child and their connectedness to their community, to their school, to their family, offering that family support, and perhaps reinstating some of those referrals if families have lost their way or need extra guidance. And recapping on those simple things that Philippa talked about, the sleep, the nutrition, and these things all change as the young person goes through adolescence and becomes a teenager and has puberty and has other stressors. In addition to all that, we then do the co-prescribing. And so this involves getting a S8 permit to prescribe, and it's just the same as getting a permit for opioids. If we can go on to the next slide, please, Lawrence, just to recap everybody's memory. I always have to Google it. Schedule 8 permit and notification comes up from the Department of Health. There's 4 boxes to choose from, and it's actually number 4 for my patient is not drug dependent, but I still want a S8 medicine, and then goes on to the treatment details. We're very lucky in this setting, coming from the branches clinic, all of these details are already determined for us: the name of the drug, the dose, how much we need, and the frequency. Sometimes if the dose needs to be a little bit more, you can put the higher dose and it'll be a max dose. But most of the patients come back from branches with a particular dose of a particular medicine, and there's very little variation. Sometimes then the permit will come through very quickly, and sometimes it will take a little bit longer. So whenever you get the referral back from branches, it's good to have the patient come in and do the permit early. Like, don't do the permit on the day that they first need the medicine and it's the last day of their supply, because sometimes it takes weeks, sometimes it takes hours, and I don't know why. But what have we got next? In terms of the co-prescribing model, it's so they'll come and see us in that 6-month mark, and the 1-year mark and the 18-month mark if they need, for their script, and have the follow-up with the paediatrician at the 2-year mark, and that's the minimum requirement. With branches, currently we're reviewing at the 1-year mark, just to see how it's going. I think one of the biggest problems that I face as a GP, and that potentially everyone else will face going down this path, is it's easy to write the script, it's easy to get the medication. But what happens is the families or the children come back and they say global statements like, it doesn't work anymore, or they're really angry on it now. And it's really hard to troubleshoot those generalized statements when you're not overly familiar with the medication. And it's taken me a long time to be comfortable to say, well, that's perhaps not the medication, because initially I was just always assuming, well, it must be the medication, and I forgot my brain and forgot that I could explore each of those issues in more detail. If at the end of the day, after your history and you've pinpointed, really what it is, and you think it might be the medicine, one of the things with the branches clinic is we have an email address which is manned, so you can always pop those questions direct into the email. Lawrence is hoping in the future to generate a GP helpline so we can call and say, what about this? Is that really one of the medication side effects, or is it something else pertaining to adolescence, school, etc.? And at the other end of that, you can also write a letter back to branches saying, I need this patient reviewed sooner than the 1-year or 2-year mark with this particular issue. So it really is not a scary thing for GPs to get involved in the co-prescribing. I think there's a lot of uncertainty from time to time with certain practitioners, but probably all the ones that have come along today, thank you, want to be part of it. And I'm here to reassure you that it's easy. It's easier than it seems. And in this setting, we are very well supported by our paediatric colleagues. And then here for your reference is some links to useful websites that you might want to explore later. Thanks, Lawrence.
Thanks. So I think that's the end of our slides. I might stop the share. And I think we're handing back to Bianca as the facilitator for our Q&A.
Great, thanks, team. Fantastic presentation. Yeah, it's great. There's some questions in the chat, or in the Q&A. So if you've got a question and you haven't yet popped it in, just go to the bottom of your screen. You'll see Q&A and pop your question in. So I'll kick off. We've got questions related to screening, diagnosis, to medication challenges, and to allied health access and pathways. So first question is around inattentive ADHD in teenage girls. Questions about when with the screening of use of Vanderbilt in this case, where you're asking the teachers and parents. The teachers are often seeing a masked side. So the parent may see them unmasked, the young person understands themselves unmasked, but the teachers don't necessarily see this. So how do you help them reach a diagnosis when two areas of the child and parent sees, two areas of behavioural challenge need to be documented? And
Wow.
Dave, I know you've answered a lot of these questions, so do you want me to throw to you to kick us off with the answers?
Sorry, it's bad. I've put answers to all of them. Just jumping in, my opinion. I'm happy. Why don't I have a go at this one? But why don't we let others have a go at others essentially? But I think this is an interesting one, isn't it? Because the diagnostic criteria stipulates that it needs to be present in more than one setting, but it doesn't say that everyone in that setting has to be able to see it. And I think it works really well for the hyperactive boys who are creating havoc, and it's a pain in the neck for the parents and it's a pain in the neck for the teachers, and so everyone sees it. But exactly as Ern has said, the inattentive types, and they're often inattentive but with high IQ, and they can cover it very well, but have a lot of associated anxiety with that, as well, as Pip sort of demonstrated very nicely with her case presentation. So I just look to other informants, and the nice thing with teenagers is that they're a reliable informant, and they can often describe. And it's interesting, actually. Sometimes the parents don't even appreciate the degree of difficulty that they're experiencing, and that's one of the things I love working with adolescents about, is that you get increasingly insightful commentary on how it's impacting them. So it's not an uncommon situation to find low scores from the teacher, but I think I want to correlate that with history and with feedback from the young person themselves.
And Dave, your practice wisdom from, well, it's not really what age, but what stage, or what are the indicators that, you've got a reliable informant? At what age are you kind of finding that you're less in need of that triangulation and more trusting the impression of the young person themselves?
I mean, the most recent one where I've done this with a girl in grade 6 who was 12. So I think, I think from high years of primary school onwards, really, and it depends a bit on the maturity, and you make a little bit of a judgment as to, how reliably. And look, there are some kids in grade 5 or 6 that you'll get a grunt from and not much more than, but there are some you get quite sophisticated description of things as well. So I think it's a bit horses for courses, but definitely in the higher years of primary school onwards, I think you can. That'd be my experience, but interested in what others think.
I think, Dave, that I just wanted to say that I love asking children of any age, not just what they notice, but also I find a really interesting one is asking them how they perceive the medications once they're on them. Because I think when you're trying to really tunnel down on what it is the child is getting from this medicine rather than what the school is getting from the medicine or the parents get, they come up with all sorts of quite intriguing interpretations of whether and why it may or may not be helpful for them. And there's lots of good questions in here about loss of spark, which I know we're going to get to. But I think self-identified loss of spark is a bit of a heartbreaker when you're in the desk opposite, because you think, God, I'm just trying to help, and I've stolen something from you with this stupid medicine, which we wouldn't need if we all lived on big properties with horses and ran around outside 90% of the time.
If riding a horse could be our occupation and in our contemporary society. and it might be. So okay, let's get into some of those medication. Oh, I'm coming to you, Ern. I'm coming to you live. So let's go to mood variability related to change in medication, specifically Vyvanse. Who wants to take that one, team?
Sorry, what was the question, Bianca?
So is mood variability related to change in medication, specifically Vyvanse? So Dave's kind of thought, we've just happy for Bhuvaneswari to clarify a little bit. There might be a little bit of clarification required, but if the question's related to increasing dose and seeing mood variability, then how would you answer that question? Or is it related to the height of the dose? So just really, I guess, your impressions on mood variability with Vyvanse.
I think I might just have a little go at interpreting it. When we think about mood variability, I think I'm thinking about like mood as in depressed mood and lowered mood as potentially being a side effect of the medication itself. And when I think of the Vyvanse, I don't think of, Vyvanse as itself having its own special group of, side effects of A, B, and C. I kind of think of the stimulant families as having very similar side effects. You kind of never know which side effects you're going to get with each stimulant, but you do sort of have an understanding of how long each is going to last and when the peaks are and when the troughs are and when they're going to wear off and that sort of thing. So I think if I saw something like mood variability, i.e. lowered mood on any stimulant, I would be looking to put them in that group of, are they in that 2% of kids that are experiencing a lowered mood from this medication? Or as Mia, beautifully summarized before, is there something else going on in this life where there's kids all of a sudden getting bullied, and until you sort out the bullying, no matter what you do with the medication, the mood is going to continue to drop. So I think that's a great, point to really, which I didn't do in the slide, and Mia, you've done beautifully, is like, we've got to think about the medications and the side effects and the 2%, but also kids on medication of ADHD or any kid can have a lowered mood from a whole bunch of reasons. And that, as I said before, is becoming far more common over the past 30 years due to this social climate change of how we're raising children and how society is affecting children's mental health. Bit of a depressing thought.
We could make that the next webinar, I think. Why don't we tackle that in another? I'm interested, Pip, you described you used a tool prescription. So I'm guessing you're using that one with monitoring afterwards. And if you've got any other recommendations in relation to use of tools for that support monitoring.
It's a pretty straightforward stimulant side effect rating scale. If you put stimulant side effect rating scale PDF into Google, you'll come up with it. Or potentially we could ask Dan to work some IT magic and put a link into the webinar notes. Certainly I would use the same scale further down the track, either with dose changes or in situations of complaint about perceived side effects. And just as Mia mentioned, really using the rating scale only as a conversation prompt to really try to get a sense of what's happening in the young person's life. Sometimes the mood variability, that's a relatively common concern that can come up with all sorts of different kinds of medications, and certainly some families will, start blaming a tablet for, erratic moods, irritable responses, behaviourally, finding that there's more slammed doors or more back chat. I can't do an ADHD webinar without saying the name Bernie Jenner. I once heard Bernie give a lovely description of ADHD medications as being as if once you are well treated and your ADHD symptoms are suppressed, instead of skimming across the top of the waves, going at 1,000,000 miles an hour, you might feel the dips and swells of the waves and the tides in your emotional and mental health as well. And so parents need to be ready for that. And some teenagers who might present with mood irritability on stimulants will actually, if you kick the parents out of the room and take a much more detailed history of what they're feeling, they might describe that pre-ADHD treatment, their brain was so cluttered, so overwhelmed, so buzzing that they actually didn't slow down to notice social responses from their peer group, to pick up on subtle disapproval cues from their teachers or their parents. And they started to really, once they were on tablets, they started to become much more aware of some of the effects that their ADHD or other aspects of their life, were having on the people that they loved around them. So they started to actually then, with more insight into their own relationships and their own networks, then started, questioning themselves and seeking out more help. So it's not necessarily mood irritability isn't a bad thing. It's something that we need to unpick rather than necessarily blaming it on the tablet and changing a dose.
There's a lovely expression in mental health care, which is that we might not get you better. We might not get you feeling better, but we may get you better at feeling. And so I guess these kids are kind of experiencing having to learn some skills that they might not have, and the parents are having to face a challenge they haven't faced. It's a different challenge. And so can you comment a bit more? I want to hear your thoughts on that loss of spark, because, Ern's opened it up to debate, like loss of spark. He's seen this, parents discontinue for this reason, but, should we normalize this response? Actually, if they're getting better at school and if their goals are academic, should we cop a bit of loss of spark for longer term educational goals, or are we really looking at it as a bit of a deal breaker in terms of identity formation and some of those other tasks of adolescence and social emotional communication? Your thoughts? I know you said it's a deal breaker for you.
Well, actually, I might jump over this because I had an adolescent where this happened, right at the start, and they lost faith in the medication, and we held off. But then over a period of time, whenever they experienced lots of difficulties, they went back on the medicine. And I think they end up finding this balance of realizing that they lost something that was, they valued a lot to a certain extent, or had it dampened. But then they had all these other benefits in the rest of the life. And this adolescent went to the gym like 3 times a week, and I think he really loved that, and that part of his socialization for him was important. So, and the beauty of the adolescent is you can just ask them what they want to do and where they're impaired. And so, for me, I think that was one kid recently where we had that loss, but we ended up back on the medicine for a number of reasons. And for him, it was a really interesting journey for that 12 months as he discovered that.
Can I ask, these medications like your SSRIs, where you need to build up and keep a steady state, or, can kids decide actually, Monday's a really tough day. I've got maths and science and there's high demands, but Wednesday we do woodwork and PE.
Totally.
Can they just decide to take it some days and not?
The beauty of the stimulant, and like, some days I've got some kids in tertiary education, or young people in tertiary education, don't take anything on some days, and then they've got a more intense lot of lectures, and they might take a long acting, or they might even just take a short acting as well. So yeah, incredibly flexible in how you can use it. I have occasional kids where if they're not taking it every day, then it seems to take a little while to start working when they start again on Monday, but that would be a handful over the years. I think most of them you can just start, whenever.
So great. It's going to segue into a question about dose titration. GPs would love help with dose titration between pediatrician visits within safe limits, like adding on short-acting Dex and Ritalin for the midday boost. So when authorising GPs co-prescribe to facilitate the DH permit, do pediatricians allow a range like the adult psychs do? Did you want to take this, Dave? I know you've had a little bit of a thing, or you've had a response already.
I think we should. And I think what this sort of highlights is that we haven't really partnered with GPs much in the past to do this. I know there's been the occasional paediatrician who will try and get, the GP to prescribe the same scripts, but absolutely, I think there's a lot of room, and that's what we want to work with you all to try and make sure you're comfortable with that. So I've started putting dose ranges and suggestions in my letters, because once I understood that you needed to have that to have permission to be able to prescribe not just exactly the same dose as I did. So no, absolutely, I think it's something, and this is something I think we can work on. And I think we've got some plans, Bianca, to do some sort of more focused work next year on how we actually build a better system and network to work together as paediatricians and GPs as well.
Yeah, thanks, Dave. So just to respond, Jenny also asked, are other PHNs being supported and is Westfit communicating together on this model? Yes, so we are. So we're going to plan to run a series of 5 echoes as part of our Population Health Echo Network on Thursday morning. So in collaboration with you guys and also for the Grampians region, our Ballarat colleagues are really keen to participate too. Now, they may have a different model, of course, and we'll just work with that very much that place-based approach. But I think the beauty of what we can do through unpacking those longer conversations is, just as, really, I guess it's trying to seek that understanding of each other's disciplines, as you've done by working through the clinic, Mia, and think about how do we co-design shared care in a way that works for both. Mia, you wanted to comment? Yeah.
Yes, I just wanted to add something to the comment regarding the scripting in the permit, because I inadvertently found something out last week. When you actually apply for the permit, you name the drug, but you don't actually have to name short or long acting. And so I recently changed, it was an adult patient, but I changed an adult patient from the short acting preparation to the long acting. And I set about trying to get a new permit and then realised that it was non-specific, it was the drug. I'd been given a permit for the drug, so I could just change to the long-acting form. Now, that was Ritalin, so I was lucky because there's not always a direct short-long. But that was a small win that day when I realised that. And I did have a range. I'd had a range, and then I could change to the long-acting preparation within the guidelines of the permit.
Awesome. So you have a permit for methylphenidate, and then you can use Ritalin LA or Concerta or short-acting Ritalin.
Yeah.
And obviously, Dex and lisdexamfetamine are different drugs, so you couldn't change quite a bit. Yep. Cool.
Okay, so then I think let's scoop up a few around allied health. So I guess there was a little bit of a complication that one of our GPs that understands Medicare system better than I do has picked up around accessing allied health consults and neuropsych assessments. Lawrence, you found a workaround, I hear?
Well, so we knew that we're moving from a Medicare funded clinics, which would have been the backbone of all the outpatient clinics in the past, to a different funding model. We don't apply Medicare item numbers to these patients when they see us. Therefore, those item numbers that used to trigger certain other flow-ons, like the 135, aren't valid anymore in this clinic model, which is was a real challenge. We have a workaround because we still have some Medicare funded clinics where essentially we do a one-off roll through that clinic where we're essentially agreeing with our colleagues about diagnoses and moving them back to the main clinic as a way of accessing item numbers. The difficulty isn't, I think, that, the 135 number itself, though. I think that so many of these patients actually just can't access anybody to act on the outcome of 135. They would love to pay for a allied health support in any form, whether it was somewhat reimbursed or not. But we have a huge problem with accessing allied health supports in the community without very specific diagnoses, which funnels you into a particular pathway under the NDIS. Because so many of those allied health supports, which would have previously been available for children with mere ADHD, are now working in the NDIS system and no longer available for patients without NDIS funding. So we have a workaround in our clinic. I don't know if it'll be long-standing. I don't know if it'll stand up in the long term, because I just don't think that it's realistic in our funding models. But I think that the bigger problem sits with availability of allied health resources.
Speaking of allied health, thank you, Lawrence. Allied health resources, someone commented in that they didn't identify a psychologist as part of your team. I think you've answered in the chat.
Yeah, so I have rather cheekily answered in the chat. I think the allied health mix of our case conferencing team, I would love to have all sorts of different people. And in fact, the breadth of the team helps. The more we get different people with different experiences the more we can pull in different resources and learn from each other. And a bit like our lovely GPs, working with Mia has been great, but there will come a time when we rotate Mia out and she goes and teaches the world how to do this within her clinic, and we bring in someone new. And I think of the allied health team similarly. So I'm very open to psychologists joining our team. And we're also, obviously within our health service, we have the CAMS service, Child and Adolescent Mental Health Service, which is kind of the pool of most of our psychologists that we work with regularly. And we're working really closely with them around some of the challenges of ASD diagnoses and things like that, and funded ASD diagnoses. But we're also working with them more generally, trying to understand how we can help each other more. So I think we're going to have external allied health as part of the team that will include psychologists, and we're going to have internal access to CAMS and work with them. But interestingly, in Colac, I've got 2 fantastic psychologists who've agreed to be part of the team, which is really exciting for us, because I think it's going to provide a different perspective there that's very unique, because they've been working in Colac for quite a long time, bring a lot of experience.
Great, thanks. Transitioning to adult care is tricky. So what we understand about co-prescribing is that we need to have 2 yearly specialist reviews for GPs to now prescribe these medications. But once they transition to 18, and then I think there's a general consensus, there's a lack of adult psychiatrists who are taking on patients. Potentially, we're a little left in the lurch. Mia, what are your thoughts on this? What have you been thinking about this group of patients?
Yeah, this is a really tricky one, because it's near impossible to see an adult psych, as we all know. I think it comes in the planning phase from 16 to 17 to plan, so you can sit through that long referral. And sometimes the kindly paediatricians will do an 18, 19-year-old. Well, that is waiting. I haven't got a good go-around solution, and I'm not sure there is one. I think from my point of view, I always encourage the young person to consider getting a psychiatrist or getting that support, because a lot of 18, 19-year-olds want to get off the medicine, want to get away from their parents, don't want anything to do with it, and then come back at 20, 21 and say, oh, you know what, that medicine was good. Could I have some again? And then you've got a very difficult path to get it. So I always say to them, even if you don't want it, just keep someone available to you. But it's early referral. It's doing it at 17 and waiting the 2 years and having the paediatrician take it until then is the current situation from my point of view. It's not really a solution, but that's what I do.
Okay, no, that's great. Thanks. Do the adult psychs that, there are a number of, I've been hearing more and more, and I think it's probably up to us to maybe review the quality of some of these services. But I know a lot of people are now recommending some of those tele-psych options. I don't need to see the person face to face as an initial, do they?
No, they don't. And I do use them because I've got nothing else. I've hit a few obstacles lately because it depends where the psychiatrist sits, because there's state-based rules and they're all variable. If I get a psychiatrist that sits in a certain state, they can't do the start and the titrate, and they lump it all on me, but I can't get the permit in Victoria that does that. So it's really tricky. If you get it's very practitioner dependent, like everything. I've had a couple of excellent psychiatrists who, depending on their appropriate state, have been more than useful, helped with everything, handed over nice and neatly packaged. But those consults are $800 plus. Yeah. And we're talking about people who are 19, 20, 21, particularly if you're going to be engaged in tertiary education, haven't got that type of money. For something that should be a little bit more freely available. But
I think some of those ADHD clinics where you're almost guaranteed a diagnosis if you go, and you pay that order $800 to $1,000, and I expect some of them are okay and some are variable quality. I know Albert Road Clinic has a number of psychiatrists who still have openings. So, I mean, I guess if you're prepared to go slightly further afield than Geelong, and their gaps aren't as ridiculous, like only $500, makes me think we need to put ours up. But anyway, better than 1,000. So yeah, it is tricky, isn't it? Really, and I mean, I guess you can make some use of the 2-year rule too. In that, I mean, some of us are stricter or less strict than others in terms of, you know, at what stage we stop seeing people. But yeah, even if you have a PED see them at 18, you've then got 2 years. Because until they haven't had 2 years without a specialist review. So I think many of the P's would be happy to kind of be the background nominated person if the GP was running it. I have seen a couple of 20-year-olds recently, but I'm probably a bit softer and more flexible or open to flexibility. Although interestingly, the medical indemnity organisations are now some of them are starting to show some interest. So I'm actually paying a little bit more in my premium because I'm seeing children over 8 or young people over 18 now than no. Whereas previously it wasn't questioned. So yeah, watch this space. I think people are getting stricter around exact age cutoff.
Thank you. I think we should probably make transitional care models part of our conversation next year.
Indeed.
Obviously,
yes.
it's to engage the psychiatrists in that conversation as well. I don't want to leave the webinar without asking this question, and I'm just conscious of time, though. We've only got a few more minutes to go. And Jade, I don't know, you tell me how much time you want us to have to wrap up. But I think it's an important question that's been asked about cultural issues and ADHD screening, assessment, that preparation with family and also management. You look like you were ready with a response.
Look, I think it's I mean, it helps a lot if you've had a chance to get to know the patient and the family. I think it also the age that they are presenting with the question and what their real question is, who is driving the concern, who is the most concerned about the ADHD symptoms, and does the degree of concern and the request for pharmacological prescribing, does that match the impact on the young person's sort of daily functional life? So if it's a teenager, progressing, they might have had a, revolting year 8, year 9, and I know for a lot of healthy, neurotypical ADHD teenagers and non-ADHD teenagers, and I know year 9 is a bit of an academic write-off, time of great social and emotional rewiring of the teenage brain, but it's not a year when parents can realistically expect a huge amount of academic progress, I think. If there are sort of cultural questions coming along where I get a sense that the teenager's own school goals and what the teenager finds a satisfying week of school is completely out of step with the parents' cultural expectations of what grades or feedback or future career path the parents might have aspirations for their teenager, I would be very hesitant to go down a formal diagnostic and ADHD prescribing path unless it's clear that, there are some cases where there's actually a 3-way disconnect where we might have a teenager who really doesn't see what the big deal is okay with barely passing a lot of things and maybe getting pretty consistent detentions and suspensions for impulsive and sort of challenging erratic behaviours at school. The parents may be having an academic drive and concerned that the kid might be kicked out of academia or whatever if their grades don't pick up. And actually, I'm concerned on a very different angle. I might be concerned that this young person's going to end up pregnant. They're going to end up stealing a car, wrapping it around a tree. They're going to end up getting addicted to something. And we know that really effective ADHD treatment is protective against substance use in adult life. So the cultural question there is, I think, it's a serious challenge and one for much bigger brains than mine. One patient at a time is the best I can do.
One patient at a time. Thanks. That's a great response. I feel like that's a nice place to finish, but I don't want to leave the question about the ASRS hanging. And Dave, is that the Vanderbilt? Is the ASRS the Vanderbilt?
No, it's a separate, so I just have to Google it. It's the Adult ADHD Self-Report Scale, and I think it's what the adult psychiatrists use. So it's a simpler scale, and so I guess it's been standardized in adults. It's a bit like if your sodium cutoff's 136 and your sodium level's 135, it's kind of where do you draw the line? So I suspect it's been standardized for 18 plus, but 17-year-olds look like an 18-year-old that's sort of mature. So that would be my approach. But I think it would be a reasonable thing to do, particularly if you're going to be engaging with a psychiatrist rather than a paediatrician. I mean, the downside of using an ASRS is that none of us paediatricians will be familiar with it. So that's the reason for using Vanderbilt if you're referring to us. Whereas if you're referring to a psychiatrist, I think that is what they use, the ASRS. Do you know, Mia? Have you come across it? No.
I've been mucking around with it. I know that because the Vanderbilt's, there's not an adult version of Vanderbilt.
No.
And but it looks like it's an 18-point scale that has sits grays out very often. And if you do the checklist, you'll find a lot of these teens that I think they're presenting, it's looking at how many points they add up in that in the grey zone. And I think through that question you can here we go, get them through the referral to the psychiatrist administer before a more detailed DIVA talk. Okay.
I mean, I'm just looking at the ASRS, and the questions are a bit more like, I think that's one of the things with the Vanderbilt. It's very school focused, and it's makes a stack of sense in primary school and early high school, and then you start to do more adulty activities as you get through teenage years. So look, it is a bit more age appropriate in a way, the type of questions that are being asked. But I just don't know how to score the ASRS personally.
The times that I've seen the questionnaires done in adults to meet the diagnosis of the two settings, that my patients have had to provide 12 years of school reports to help see that it dated back to school and it was prevalent then to meet criteria, and gone to significant trouble, obviously, to provide that information. But I don't know how they get across that two setting, but that's how I've seen it done. But I don't know how they use that questionnaire. They usually use 3 or 4 to get to where they get to, but I haven't familiarised myself with that. But that's one thing, by using school reports to meet historical criteria.
Well, it's a rich conversation, and one I think we can spend a lot more time unpacking. There's a lot of nuance, and there's not only, I guess, some of those really great, clear things that we can learn from you guys, but also that practice wisdom. I think the challenge with, this at the moment is that when we think about our typical kind of care journey, we'll often want to start with the GP recognising and perhaps screening for something, referring for assessment and diagnosis. We then spend that time with psychoeducation and preparation before intervening with medications and lifestyle and psychological modifications, monitoring over time and looking at recovery. And because of our bottleneck at the moment, we're really having to kind of flip the order, and people are taking a very curly pathway. And in a sense, what we're potentially doing as GPs is recognising and maybe screening, thinking about a provisional diagnosis, whether we actually share that provisional diagnosis with the patient or not. It's probably going to be a little bit about our sense of confidence in use of these tools. But often if they're coming wanting a referral, they're wanting something different. While that referral's in place, the GPs have expressed they want something to help them prepare patients to maybe start doing some of those lifestyle and behavioural modifications, perhaps managing the comorbidities, maybe managing the driving anxiety if that seems to be the driver. While we're awaiting diagnosis, by the time they get to you've hopefully, if we've done it well and if we've tapped into all the resources that Dan's shared with us and Lawrence has shared, they've already had a good chance and a good crack at behavioural modification by the time they see you guys. I don't know. Have we kind of placed the vision and the dream for streamlined shared care up to the point when they come to you?
Yeah, I reckon. And And then it would be even nicer if we could change the system, couldn't it? So you could do more in the passage of time. So that's the that's the macro system, Bianca, to change, isn't it? I was just going to say
regulation and funding models.
Yeah, absolutely. Yeah. I was just going to comment, Ern's just commented that the ASRS gets them through the referral door. The psychiatrist administers the more detailed DIVA tool. So Ern sounds very across it. So definitely should engage Ern next year.
Ern, come join me at Echo. You can be my GP lead. We always need to work out how to get through the gates for GPs. That's often part of what we're thinking about, is what gets people through the gates. And so these tips are fantastic. And then we've just got to work out what we do while they're waiting to jump those hurdles. So I think it'd be great to crack in a bit more to some of the resources, Dan, that you've shared. Is your website live? Do you want to whack it in the chat?
Yeah, so just on a side note, my PhD, I've built a website which we piloted in Geelong to help parents find ways of managing their child's mental health problem, of which ADHD is one of the problems listed in there, along with anxiety and depression. So it lists strategies, group programs, and individual therapists who can help with a range of those issues. So this is built for families waiting to see a paediatrician. It lists child therapists. So you're welcome to have a try, so long as you'd promise to give me some feedback, because I want to know what the experience is of GPs. This has just been built for families, but I don't know if it's something that GPs want or would use, or what they like or don't. So email me findways@mcri.edu.au if you've got any feedback. I'll plug that in there as well.
Great, thanks. And I think it's probably a nice finishing note.
Thanks, Bianca.
Yeah, thanks. Thank you. That's great. Finishing note from me. I think this is a perfect end. Ern just reflects that perhaps any child or teenager presenting with another mental health diagnosis really we need to be thinking about ASD, ADHD. So in a sense, that presentation with a mental health diagnosis, when we've looked at all the things and it doesn't seem to add up with, some of the common things like bullying or perhaps family violence, could this be undiagnosed ASD, ADHD? Could be part of our broader formulation. I think that's a great idea, Ern, and it's certainly the practice that we're now putting in place for all our young people through the DIS program. And I think it would be great if this was practice that we create that rich formulation and we look at all the things: autism, ADHD, eating disorders, family violence, just look at learning disorders, think about all the things that can drive mental health issues in children and adolescents, because this is the time when they crop up, and what we do in these first 2 decades can have a huge impact throughout the life course. So we're in a great position as primary care to be picking up and thinking about these things. So thanks for evaluating us tonight. Tell us how it went. Always the case. We always fire up lots of conversation towards the end. Sorry, and thanks to anyone who's still hanging in there a few minutes over time. But it's been great, and I'd like to thank all the paediatricians and GP specialists who have come with us tonight: Dave Fuller, Philippa, Shilson, Mia West, Lawrence Gray, and Dan Peyton. Thanks all, and we look forward to seeing you at the next webinar.